nearly 20-year collaboration with GW-ICC, and we're very happy to have this shared joint session this afternoon. And you may see that it seems a little bit out of order, but by the end of this session, I believe you will have a good understanding of the heart failure process from early diagnosis all the way through cardiogenic shock and ultimate mechanical support, and even transplantation as necessary. So I'll start off by talking about the latest treatment of cardiogenic shock. And I have no financial disclosures. So I think what we all realize is that the incidence of cardiogenic shock over the past couple of decades is on the rise. And it's not only doubled for patients following acute myocardial infarction, but also for heart failure patients. And unfortunately, despite this rise, as you see on the top graph, on the lower graph, unfortunately, mortality has really not changed much, and that will be a recurrent theme throughout my talk, despite advancements in technology. And now, really, the number continues to be about only 50% of patients surviving to discharge. So if you want to put this into perspective, unless you're under 40 years old, if you present to the hospital with cardiogenic shock, your chances of survival over the next 28 days is less than if you had contracted the Ebola virus. So through this, I'll give you some goals of a shock protocol to identify common clinical and hemodynamic markers of cardiogenic shock, understand an initial approach to management, including high-risk PCI for those with coronary disease, and think about time to mechanical intervention as analogous to door to balloon time, or so-called D to U, or door to unloading. We always need to trigger early multidisciplinary discussions with our heart team. We need to also consider temporary mechanical support when that's appropriate, like Impella, ECMO, and we'll go through some of these devices. And we also need to have goals of care discussions and shared decision-making with the patient and family in these high-risk situations. So the definition of cardiogenic shock was variable, and there was a lot of problem with treatment really over the past couple of decades until recently. And as you can see by the shock trial around 2000, the IABP Shock 2 trial around 2010, and even the ESC heart failure guidelines several years ago, there was a lot of variability in the definition of cardiogenic shock, with commonalities being systolic blood pressure, presentation less than 90, and signs of clinical end-organ hypoperfusion. But SCI, along with endorsement of ACC and AHA in 2019, came out really with very workable definitions and stages of cardiogenic shock, as you see here, with this pyramid of A to E, from at-risk patients, which might include those with acute anterior myocardial infarction on presentation, all the way to those that had classic presentation, again with hypotension and signs of hypoperfusion requiring fluid resuscitation and perhaps some lower level mechanical support, all the way to the extremis or E stage, which oftentimes was post cardiac arrest and did require high levels of mechanical support, like with Impella or ECMO or ECPella together. So this is actually a very worthwhile classification system, and I think it's been validated that it's accurate. As you can see here, when you look at the stages of cardiogenic shock on the left and then compare the graph on the right, and you can see that the observed mortality both in the CCU and overall hospital mortality correlate very well with the stages of shock as has been identified and defined by SCI and ACC. So folks often ask, well, what's the most important catheter I can use for support in my patients with cardiogenic shock? And despite the thoughts that we want to rush to Impella and ECMO or tandem or balloon pump or whatever, no question about it. The most important catheter we can use is the pulmonary artery catheter for hemodynamic profiling. And as you can see on this slide in gray or black, particularly in this area down here for stages C, D, and E shock, there's a reduced mortality, the black bars, in each of those levels of shock with the use of pulmonary artery catheter for hemodynamic profiling and guiding your subsequent therapy. And Tarani came out with this interesting cardiogenic shock risk score several years ago, in which we can take some of the factors that we think about for shock, like lactate levels, presence of comorbidities like diabetes and dialysis or elder age, as well as a couple of the newer things like the hemodynamic parameters of CPO or cardiac power output, or PAPI, or even Presser's duration from diagnosis, lasting more than 36 hours. And all of those have a whole number of points that you can put into this risk score. And as you can see, it's pretty accurate at really describing high-risk patients with worsening 30-day mortality risk. So the goals, I think, of an early cardiogenic shock protocol are to identify acute coronary syndrome and proceed with revascularization as soon as possible when indicated. If it's not acute coronary syndrome and it's heart failure or another etiology, then identify the etiology of the shock state and treat it appropriately as well. We always want to maintain adequate tissue oxygenation, utilize our pharmacologic support, and I'll talk about that in just a second. But we also want to think about avoiding negative inotropic agents. We want serial responsive therapy to be monitored, again, with a pulmonary artery catheter, and think about early institution of mechanical support when indicated. So this is a typical medical school grid that we all had to learn about the various positives and negatives and effects of all of the pharmacologic vasopressors and inotropes. But the key thing to keep in mind is in the red down here before or below is that they all increase myocardial oxygen consumption. And furthermore, none of these singly or in combination have been shown to improve mortality. And in fact, from the CVAD registry, you can see that there's increasing mortality according to the number of inotropes that are employed in our patients with cardiogenic shock. So that's really pushed us now into a new territory of looking at mechanical support as a better supporting program for our patients with presenting in shock. Now, my friend Holger Thiel has been very active in this area and has had a number of landmark trials that have come out, including one I'll show you here in just a few seconds. And first of all, several years ago with the culprit shock trial, he showed that PCI for STEMI at any time patients presenting with cardiogenic shock, that one should only do the culprit lesion only and not try to do complete revascularization. And by doing that, you maybe improve the overall usual mortality of 50% down into the lower 43% range versus those that have complete revascularization. And that was true not only at 30 days, but at 1 year, and not only for mortality, but also for reducing dialysis. So I've seen some of these cardiogenic shock talks with mechanical support end with this slide where they basically say, well, there are no randomized trials that show any of this is effective, even though these agents can bring about various levels of mechanical support. It's indeed true. There's not been any positive randomized trial that's shown that any mechanical support has improved mortality. And as you can see, the various levels that you know of increasing from balloon pump at 1 liter support all the way up to Impella 5 or VA ECMO that can give you up to 5 liters of support per minute or more. And again, as I said, these are some of the randomized trials to date. I'm going to show you a more important one from ESC just a couple of weeks ago. But all of these trials did not show that any of these mechanical support methods actually improved mortality. But what has improved mortality is a shock team approach. And as you can see on this top line here, the shock team really is, again, this whole shared decision-making process, which I think throughout cardiovascular medicine has really improved our outcomes. But in terms of shock team, you have the critical care cardiologist, advanced heart failure person, an interventional cardiologist, perhaps for mechanical intervention or PCI, cardiac surgery when that's indicated, and an ECMO service. And all of these can be deployed rapidly and hopefully make good early decision making. And with a shock team approach, we can see in the dark blue bars down below, there's increased use of pulmonary artery catheter, of advanced mechanical support, and actually reduction in ICU mortality. And Tarani has also shown us that this is true not only for patients who present with acute myocardial infarction and cardiogenic shock in blue, but also for those who present with advanced heart failure in red over a sequential 18-month period of implementing a shock team protocol. Okay, here's Holger Thiel back again about 10 years ago, showing with IABP shock trial that early institution of a balloon pump in patients presenting with cardiogenic shock had no effect. And again, you still see that recurring 40 to 50% mortality rate in 1 month in these patients presenting with shock. I will say that a disclaimer has been that 86% of his balloon pump insertions were after revascularization with PCI, and that's contra to what you've heard recently about patients in utilizing Impella prior to PCI. So there is actually in development a study to look at earlier institution of balloon pump before PCI to see if this may make a difference on another randomized trial. So here he is again, just a couple of weeks ago. I shot this picture and have brought it to you. Again, this now was the ECLS, the ECMO trial, 30-day mortality versus best standard care for shock patients. And again, you can see similar sort of Kaplan-Meier curves as we saw before at that 48, 49% mortality at 30 days, whether one had institution of ECMO for cardiogenic shock following acute myocardial infarction or best standard therapy team in a randomized fashion. So he's shown with his team pretty well that both balloon pump and ECMO really have not made a difference in the 30-day mortality in these patients presenting with cardiogenic shock. The disclaimers would be the balloon pump was done after PCI, and others have challenged that these patients, many of these were several days out and were not the typical shock patients or the ones that might be best served if they presented within 12 hours. Again, there's always a study that promotes or provokes perhaps a restudy. But at this point, ECMO and balloon pump have not been shown to improve survival in shock. And in fact, the patients in the ECMO arm had, as you might expect, increased vascular problems and bleeding. Now, something we've been a part of was the National Cardiogenic Shock Work Group, and initially out of Detroit and Boston, which was about 5 years ago, looking at patients again with acute myocardial infarction, and then early identification of cardiogenic shock with hemodynamic data, and if so, then they were in the cath lab and they had implementation of Impella prior to PCI. And this was the initial group. We were not in the initial group, but have subsequently become in that work group. And again, this is an observational study. Again, not a randomized trial, but what they showed in this arm over here was 72% survival rate to discharge with early Impella use prior to PCI. And these are, this is a meta-analysis of about 15 studies using Impella pre-PCI versus afterwards. And you can see with the exception of 2 studies, all of those showed improved survivorship with our early institution of Impella. again, non-randomized. The red bars actually highlight that in these two studies, the CVAD and AMIGAS, that actually women did as well or better than men in that study. So that's somewhat encouraging. And another meta-analysis, again, of Impella pre-PCI versus post in these patients presenting with MI and cardiogenic shock. And one you can see is, again, the survivorship in red is better if they had the Impella implanted pre-PCI. Again, looking at a 66% survivorship to hospital discharge for those that were presenting in the first hour and a half, versus about 40% up to 4 hours and 26% out to 12 hours. We initially had a cardiogenic shock protocol in the Carolinas and presented that again to TCT a couple years ago, and again ended up with similar results, non-randomized, of about 70% survivorship when had early implementation of Impella prior to PCI. And again, this is just a summary of 2 decades of cardiogenic shock trials, all the way from the initial shock trial back in 2000 until some of these recent observational studies suggesting 70% or more survivorship with early Impella. So the whole theory then has been turned around, where we have this again from medical school, that downward spiral of cardiogenic shock, but hopefully with mechanical support, particularly in this case Impella, can reverse that trend towards recovery. And we also know that treatment delay is associated with an increase in mortality, and that for every 1 hour there was associated nearly 10% increasing risk of death for implementation of mechanical support prior to PCI. So again, best practice protocols, again, have not been proven by randomized trials, but are still, as I'll show you here at the end, on a couple of other randomized trials in process, is to identify early cardiogenic shock and look towards the appropriateness of Impella pre-PCI, try and down titrate those inotropes, which we know can actually be harmful, and then also support the patient in other ways, including RV dysfunction and making sure there's adequate left ventricular support and monitoring with pulmonary artery catheters. So the RECOVER 4 trial is in process, and this would be another one which may really look at the same or similar set of patients who have cardiogenic shock and from acute myocardial infarction, and they're being randomized now. It's now in process to Impella pre-PCI, and then those that will get standard care plus minus a balloon pump, which is an addition, and then look at that and look at their 30-day and down the road survival. So that's ongoing now. There's some other high-risk groups that we should talk about, because this is not just about AMI and cardiogenic shock. This is also about heart failure and cardiogenic shock. And as you can see, these overlapping sets of patients who may even need complex high-risk PCI, but also have reduced left ventricular ejection fraction or heart failure. 2 randomized trials that have been done to that. The BCIS-1 really showed no advantage of the balloon pump. PROTECT 2, which we were a part of about 10 years ago, did show some improvement in overall MACE after 90 days, although that wasn't specifically about mortality, but really about repeat revascularization. And then PROTECT 4 is the study that will really now answer that question in those patients with heart failure and a need for revascularization, whether or not implementation of mechanical support will be helpful in trying to reduce or improve their outcomes. And as you can see here, they'll be randomized again to Impella versus best care otherwise, with or without balloon pump. And that's actually got over 500 patients enrolled to date, and probably won't have those answers maybe as soon as ACC 24 or later. So in summary, then, there are a lot of mechanical support trials that have been tried or are in process. I think the ones that I probably would concentrate are on the future trials, Protect 4, again, for those high-risk patients with heart failure to consider revascularization with PCI, and also then the Recover 4, which is the acute MI cardiogenic shock patients. Dangerous shock from Denmark and Germany is also in process, but has had some low enrolling issues. So again, this continues to be difficult to answer truly with randomized trials in this high-risk group of patients. So thanks so much, and we will look forward to other talks in this session.